Welcome. In this video, we're going to continue the conversation about patient autonomy by looking at an essay by Atul Gawande. Gawande is a surgeon and is also a terrific writer. So this is an essay that's pulled from his book Complications, A Surgeon's Notes on an Imperfect Science. So here's the plan today. We'll first return briefly to Dax's case, and we'll consider what's going on with Dax as a conflict of principles. And then, second, we're going to maybe see what Gawande is saying as a counterpoint to what's often taken to be the lesson in Dax's case. So, without further ado, here's what we might remember from Dax's case, or here's a way of framing Dax's case. You'll remember that Dax was badly burned all over his body in his early 20s, and as a result of those burns, he ended up being treated in hospital for about 14 months, and especially early on in that treatment, he had to have his wounds disinfected and redressed every day. Dax described the process as basically the feeling of being skinned alive. But the doctors decided to treat him over his refusals. And part of what we find really interesting in Dax's case is that he did get better. Right. It took him a long time for him to get his life back on track, but he eventually became a successful trial lawyer, a successful advocate for patients' rights, and was a person who was ultimately happy with his life. So what we see here is really interesting because Dax claims that doctors were wrong to treat him, even though they ended up giving him a good life in the end. And part of what we see here is a few different medical ethical principles in conflict, right? So we have patient autonomy, that is respect for a patient's acceptance or refusal of certain kinds of treatment, especially when they're competent. We can talk about beneficence, the promotion of what is best for the patient. So the principle of beneficence would be focused on the fact that we can give Dax a life worth living again, by treating him, by dressing his wounds, by putting him through multiple surgeries. But we also have the principle of non-maleficence. This is the rule that we must do no harm, but more specifically, if we have to harm people, it has to have significant benefit overruling it. And we might also think that harms have to be only acceptable if a patient consents to them. Now, Dax was in his accident in the 1970s, and in the 1970s and prior, it was typical to see a paternalistic model of medicine at work. So the paternalistic model of medicine, for instance, would say not tell a patient about their diagnosis if the doctor or a spouse decided that informing that patient would be too stressful for them. Or a patient would just be given a certain course of treatment without being asked. That is sort of the old-fashioned paternalistic model of medicine. And we also saw that old-fashioned paternalistic model of medicine rearing its head in Dax's case, right? Because we might say that beneficence, this drive that the doctors had to help Dax, they let that principle win out over the principle of avoiding harm through the surgeries and the redressing of the wounds, but also they showed less regard for patient autonomy. Now, through Dax's court case, as well as a number of other famous cases in United States medical law, autonomy has tended to get increased precedence. So physicians have more respect for autonomy nowadays than they used to in what some might refer to as the bad old days. we might ask the question, what is the justification for this shift? And if you ask Dax, he might tell you it's a human rights issue, right? You have a right to decide what goes on in your own body, and nobody else has the right to force you to go through something painful, like a surgery or the redressing of wounds. Dax will even say that people don't just have the right to make good mistakes, they don't just have the right to make good decisions, but they also have the right to make mistakes. So the right to decide for yourself includes the right, we might say, to be foolish. And this shift away from a paternalistic model of medicine is reflected in the history of medicine. Now this is starting to shift to what Gawande is telling us about in his essay. Gawande tells us that in 1984, a notable book was published by a doctor ethicist named J. Katz. This is a book called The Silent World of Doctor and Patient. And this was an influential critique of the old way of doing things in this paternalistic model. One of the cases that Katz discusses is a fascinating one. So it involves a woman. In this case, we're using a pseudonym, that is a fake name that's used to refer to the patient, but it's not their actual name, so we protect your privacy. But Iphigenia Jones was a young woman who discovered breast cancer at age 21. Now, the standard procedure for dealing with her kind of breast cancer at that time would have been what they call a total mastectomy. They remove the entire breast from the patient's body to reduce the risk of cancer. But in this case, Jones's doctor decided, given that Iphigenia was so young, he wanted to give her the option of preserving her breast. Now, what would have happened in this case is both the breast preserving and the total mastectomy approaches both had an equal chance at succeeding, although there was an increased chance of the cancer returning with the breast preserving surgery, which would have required, at that point, the total mastectomy. But in this case, Jones was given the opportunity to have the breast preserving surgery, and that's what she opted for. Now, when both the doctor and Jones were discussing the decision at a medical conference, some doctors thought that this approach was completely wrong-headed. Right. So the paternalistic model said, this doesn't make any sense. They might ask, if doctors have such trouble deciding which treatment is best, how can the patient decide? And we might think that, doctor knows best, not patient, so they should be making the decision. But Katz, I think, gives a worthwhile response. The question of whether one procedure is better for a patient or worse isn't a purely technical question. It's a question about a patient's values and what sorts of risks they're willing to take. And in that sense, we might even say that a patient does know better than the doctor what course of treatment will be best for them. Now, here we're finding the story that in the old days, doctors were given leeway to decide what was the right course of treatment or the wrong course of treatment for the patient. Now here's Gawande's concern. He says, it might be a mistake to treat autonomy as the sole or supreme value in medicine, or the value that wins out over other values all the time. He does think that moving away from the paternalistic model is a good model. For instance, he points out that his own father, who was a urologist, used to deny patients the right to a vasectomy That is a surgery which makes a man sterile, no longer able to become a father by stopping the release of sperm from that person's body. Now, Gawande's father said that in the old days, he would not provide this surgery to a patient if he deemed them to be too young or if this patient did not have kids yet. But by the 1990s, when Gawande wrote this essay, he noted that his father couldn't remember the last time he denied a patient for a vasectomy. And that seems to be a good thing, Gawande thinks. But he's also going to offer some pushback for us. He's going to say, if we're always focused solely on the importance of autonomy, we might miss something, and we might actually do worse medicine. So here's a big question. What do we do when patients make bad decisions? Now, maybe this comes back to Dax's case. What do we do when a patient is, say, refusing treatment even though it seems clear to the medical team that this patient could get benefit from the treatment? Well, let's start looking at some cases. Gawande gives us a case of a character that he calls Mr. Lazaroff. This seems to be a real case, but he is using, again, pseudonyms. This was a patient with very advanced cancer. One of the tumors was near the patient's spine, and that was causing paralysis and also incontinence. And the other thing to notice about this case is that Mr. Lazaroff did not want to die as his wife had. His wife had a long, extended stay in the hospital that was traumatizing for him and the family, and he wanted to avoid a similar fate for himself. Now, there's a scene in Gawande's essay where Gawande, as a young medical resident, is coming in to explain the surgery that he's considering. It would be a surgery to remove the tumor, and which would slow and remediate the paralysis that Mr. Lazaroff was dealing with. Now, before Gawande is able to finish all the paperwork, that is, explain to Mr. Lazaroff all the risks, Lazaroff's son comes into the room, and the older Lazaroff, he snatches the paper from Gawande's hands, signs consent to the surgery, and basically says, "You're going to save me, aren't you? What do you mean you think I'm never going to walk again? Of course I'm going to walk again. I'm going to be back at work." And in this case, to make the long and short of it, Gawande lays it out a bit more in the brutality of the case. But after the surgery, Lazaroff does not recover. They had to deflate one of his lungs in order to access the tumor near his spine. And after the surgery, Mr. Lazaroff was not able to have his lung reinflate and to restabilize. So he spent a long time on a ventilator, but after it was clear that recovery was not in the cards for Mr. Lazaroff, Lazaroff's son allows the ceasing of ventilation. Now, big question, would it be ethically acceptable to refuse to treat Mr. Lazaroff? It seems that in this case what's going on is if we follow a patient's wishes, we have to throw good efforts after bad. Gawande seemed to realize that Mr. Lazaroff didn't have a great chance of recovery given how advanced his cancer was and how weakened he was in the process. We might also realize that by doing what he did and going along with his wishes, Mr. Lazaroff got exactly the kind of death that he didn't want. He didn't want to die after a bleak extended stay in the hospital, but by following his wishes, that's exactly what he was given. We might notice that if respecting patient requests is our primary value, in this sense, we've done right by Mr. Lazaroff. But if we realize that there was little opportunity to benefit Mr. Lazaroff in this case, and insofar as we recognize that he was not fully cognizant of the risks and benefits of the surgery he was consenting to, we might think that, in fact, pulling back and telling Lazaroff that this surgery is no longer medically indicated for you might have been a more apt approach. So, Gawande points out that this is an important part of being a good practitioner. He says that sometimes patients will make bad decisions, and it's a doctor's job to not just go along with the patient's bad decision. So he gives us a hypothetical case this time. We have a patient coming into the clinic. She's a woman in her 40s, a mom with a busy career, and on her yearly mammography, a lump shows up. And she is refusing, in this case, to get another lumpectomy. I say another because in this case, she has gone through a couple before. He notes that on the patient's breasts, you can see raised scars and missing tissue, basically, from previous cases where lumps were found. They were biopsied, and it was ultimately found that it was not malignant cancer. So she's annoyed when Gawande says that another lumpectomy is in the cards. Now, Gawande says this is subtle. There's an important way in which a doctor wants to persuade their patient, but you can't just come out and tell them that they're making a mistake. So he points out that it is, in a certain way, illogical, fallacious reasoning to say that simply because the first 2 lumpectomies came back negative, that the third one will also be negative. That's actually not how it works. But if a doctor just comes out and tells the patient, you're being irrational, you're making a big mistake here, that patient is not going to hear out their doctor. Oftentimes, he says, the first thing that a doctor should do is repeat a patient's concerns back. So to say to this woman, your first 2 lumpectomies came back negative, and you're suspecting that this one will come back negative as well, and it's not fun to get these surgeries. Oftentimes, letting the patient feel heard might let them come around to the next step of the conversation, which is the point that maybe it would still be a good idea to get a lumpectomy this time. Sometimes we say, let's not finish the conversation yet. So we might say, maybe we should come back for another meeting with you and your spouse. Or maybe I should send this scan over to my oncologist friend who can confirm whether or not this is likely to be a benign lump. So the way that Gawande puts it is, in these sorts of situations, he says, before a thoughtful, concerned, and yes, sometimes crafty doctor, few patients will not eventually choose what the doctor recommends. He points out that in this way, we see autonomy taking a backseat to other values. And in fact, when we look at what patients want, autonomy is less important when things start getting real. He notes a survey that says, once a cancer patient is in fact being treated, the extent to which they want to make all the decisions for themselves decreases. So if you're just imagining having cancer, you might imagine, well, I'm going to research all my options and I'm going to make sure that whatever I want is what goes. But many times when a patient actually has cancer, they're going to say to their doctor, what do you think I should do? I just want to do that. So in that way, Gawande is going to point out that we, in a certain mood or in a certain mindset, can sometimes overrate the value of autonomy. So let me give you one more case from Gawande's essay. This figure is named Mr. Howe. Mr. Howe is a patient who underwent surgery for an infected gallbladder. This is a pretty routine procedure. Gallbladder infections do happen, and it's not a hard thing for a patient to recover from. The prognosis for getting an infected gallbladder dealt with is likely to result in full patient recovery. But in this case, our patient, Mr. Howe, is recovering from sepsis. He's suffering from it, and also has pneumonia. So he's got an infection that's moving through his body. He's having trouble breathing. And these are very terrible things to go through, but they're also treatable. Right? And when a patient gets pneumonia, sometimes what is indicated, that is the solution to the problem in front of us, is that the patient should be intubated. But in this case, Mr. Howe is refusing intubation, saying he doesn't want to be on a machine. As he's making this refusal, he's becoming less and less able to breathe for himself. In the story, Howe's wife gets up and leaves the room because she's too overwhelmed. And at this point, Gawande and his chief resident, who he simply calls K, they see Mr. Howe become unconscious as his oxygen levels drop lower and lower and lower. But here's the thing. The next day, we stabilize Mr. Howe, we get his pneumonia under control, we take the breathing tube out of Howe's throat. And as he recovers, he tells Gawande and Kay, thank you, Doc. And he's saying it sincerely. Right? Now, here's another case where just going along with patient wishes is a mistake. Right? Gawande is going to say, we don't want to, for instance, give autonomy full bore here, because in that case we might say, well, insofar as we can tell that there's any patient wish, it's a patient wish that says, do not put that tube in my throat. But, as Gawande points out, a day later, the patient is glad that these two doctors overrode his wishes. Now, another observation that we might make about this case, and also about Mr. Lazaroff's case, is that these were cases of patients who were not fully competent. And insofar as they were not fully competent, there wasn't true autonomy there to be respected. That might be a worthwhile line of argument to understand these cases, and why maybe Gawande is going to say, yeah, respect for autonomy is important, but we can't try to respect autonomy where genuine autonomy doesn't exist. Now, we might ask a further question of whether this leads to the old school view, which says that a patient is not acting autonomously unless they are rational, and they're not rational unless they're going along with what the doctor is recommending to them. So whether we can make wiggle room to say that the treatment of Mr. Lazaroff was mistaken, that the treatment of Mr. Howe was good, but also still maintain that maybe Dax had a right to make a decision for himself about whether he wanted to continue treatment for his burns. So, we can reflect on all these cases and figure out exactly how the principle of autonomy is supposed to apply in these cases. But I'll end with a longish quotation from Gawande, because I think it does open up a broader question. And it seems to suggest from Gawande's point of view that we just need to remember that even though autonomy is very important and we don't want to move back to an old school paternalistic model of medicine, we also need to remember that autonomy is not the end-all be-all of medicine. So here's how Gawande puts it. He says, where many ethicists go wrong is in promoting patient autonomy as a kind of ultimate value in medicine, rather than recognizing it as one value among others. Schneider, the author of a book called The Practice of Autonomy, found that what patients want from doctor isn't autonomy per se. What they want from their doctors is competence and kindness. Now, kindness will often involve respecting patients' autonomy, assuring that they have control over vital decisions. But it may also mean taking on burdensome decisions when patients don't want to make them, or guiding patients in the right direction when they do. And even when patients do want to make their own decisions, there are times when the compassionate thing to do is press hard, to steer them to accept an operation or treatment that they fear, or forego one that they'd pin their hopes on. Many ethicists find this line of reasoning disturbing, and medicine will continue to struggle with how patients and doctors ought to make decisions. But as the field grows ever more complex and technological, the real task isn't to banish paternalism. The task is to preserve kindness. So here we might say, look, autonomy is an important thing, but it's important insofar as autonomy and respect for it is part of what a kind and competent doctor will do. We might criticize, for instance, the doctors who worked on Dax as being unkind in the way they refused his requests over many, many months. But we might say it wasn't exactly unkind for Gawande and Kay to intubate Mr. Howe. And we might even say it wouldn't necessarily have been unkind. Maybe it would have been the kind thing to do, to sit Mr. Lazaroff down and have a hard conversation with him about the fact that he didn't have a lot of time left, and that the best thing that he could do would be to find ways to be comfortable in his last days rather than trying everything he possibly could to fight this, unavoidable problem back. So this offers us at least a counterpoint, right? Autonomy is very important, but I suppose Gawande's question is how important, and we might even find cases where respecting patient autonomy per se would be a mistake. So that's it for this discussion. Thanks for listening in, and I'll look forward to hearing from you about how you think about how to navigate this conflict between autonomy, the patient good, doctor kindness, and so forth. So thanks for listening in. Take care.